communauté des neurochirurgiens marocains. Je vous remercie d'avoir accepté de partager votre grande expérience dans la chirurgie de la base du crâne avec nos collègues neurochirurgiens marocains et bien entendu des neurochirurgiens africains et arabes. Merci.
À vous, Monsieur Froelich.
Parfait. Bah, écoutez, merci à tous. Hein. C'est vraiment un plaisir de vous voir. Dans la morosité actuelle, ça fait du bien de revenir à des choses concrètes et à ce qu'on aime et ce qui nous passionne. Donc, c'est vraiment un plaisir. Je remercie la Société marocaine de neurochirurgie. On a un lien affectif ancien et actuel avec cette société. Je remercie Monsieur Cornu pour son invitation également. C'est une belle occasion pour moi de voir tout le monde. J'ai plusieurs jeunes qui sont venus du Maroc à Lariboisière, donc ça me fait plaisir aussi de les voir. On pourra peut-être discuter un peu à la fin. Donc voilà, merci. Et donc, je vais parler en anglais parce que même si c'est sous l'égide de la Société marocaine et de la Société de langue française, l'anglais va nous permettre de communiquer avec des personnes qui ne sont pas forcément francophones. So the subject of, I will now go to my presentation. So welcome to those who are not speaking French. I don't know who they are exactly, but thank you very much for joining us. Subject of my talk today is Petroclival Meningiomas. Petroclival Meningiomas is a complex lesion to treat, probably one of the most complex one to do surgery on. It's located very deep in the skull base, and it's a challenging surgery. It needs a multidisciplinary approach. It's a team surgery. Because we are dealing with an anatomy that is also part of the ENT territory, for example, even if in my practice, ENT are not necessarily participating to the approach, but we have learned with them and we are in close collaboration. Neuroradiologists are also important. Most of our large and giant petroclival, in fact, all of them now have an angio before surgery and are also embolized. It's also a pathology that surgery do not cure in the vast majority of cases when it's a large or giant tumor. So we may need a radiation oncologist for additional treatment of those tumors. And I have colleagues in my department, great colleagues, and working with them is a pleasure and make us much stronger. I have to thank also my fellows. Research fellows, they are doing some great work in the lab, research on approach, research on pathology with clinical research. And this dynamic brought by the clinical fellows and research fellow is extremely important. For this type of surgery, especially combined petrosal, I think for the young neurosurgeon who are listening today, it's absolutely mandatory to spend some time in a laboratory because it's an approach that needs really to get familiar with the anatomy and that needs some training before to start in real surgery. So petroclival are rare tumor. It's only 2% of intracranial meningioma. It's usually a very slow growing tumor and it can be asymptomatic for a long period of time. And now because we have MRI for every kind of subjective symptoms, we find a lot of small petroclival meningioma who are asymptomatic, and it's not always easy to know what to do with them. When it becomes surgical, it's one of the most difficult lesions to operate. There is definitely, in the last 10, 20 years, a shift towards preservation of quality of life and not aggressive resection like it was done before when we had not the tool of radiosurgery. There is a shift towards multimodal treatment, combination of surgery, observation, and radiation therapy. The definition is an issue because we don't always know if we are talking about the same tumor to compare our results. So it's very important to have a clear definition of what we are talking about. There is a difference between petroclival and sphenopetroclival. Sphenopetroclival originates from the cavernous sinus and extend in the petroclival region. Petroclival meningioma arise really from the petroclival region, and they do not always invade the cavernous sinus. Clival tumors are very rare. They are really located midline. I did 2 or 3 cases in my practice, so it's a very rare tumor. Endoscopy is a good treatment for it, endoscopic endonasal, but again, it's very rare. Posterior petrosal meningioma arise from the posterior surface of the petrous bone, either behind the internal auditory canal or in front of it, or all around it. Lower clivus is a different entity. The approach is different. Relationship with a lower cranial nerve is the issue. And there are a sub-classification of a subcategory of foramen magnum meningioma. So here, for example, this is a publication from SAMI of 1992. And look at this meningioma that was shown in this publication. In my opinion, this is not a petroclival meningioma. It's a tentorial meningioma. It has not real relationship with the petroclival region, except that it extends probably partially in the petroclival region, but it's mostly a CP angle extension. This is another case from a recent series, Chinese colleagues, and they show this picture of this huge meningioma. It has something of a petroclival, but if you look at the epicenter of the lesion here, hyperostosis, as well as fibrous trabeculation inside the tumor, you can see that this tumor is not originated from the petroclival region. This is a posterior petrous meningioma. And you can easily understand that for this type of tumor, the retrosigmoid approach is a nice corridor because you don't have to retract much the cerebellum to get access to it. KAWASE classification is probably one of the most accepted classification. It divided for a petroclival meningioma in 4 subtypes, depending on the epicenter and depending also on the deviation, compression, direction of the compression of the trigeminal nerve. You see that he divided in upper clivus, cavernous sinus, which means that he mixed cavernous sinus meningioma extending in the petroclival region in the category of petroclival, which I don't completely agree with. Here is a tentorial type of petroclival. It's coming from the tentorium and it's pushing 5 down. And here is a petrous apex type pushing 5 medially. And this is a category that is very controversial. For example, AL-Mefty says that this is not a petroclival because 5 should be pushed laterally. So for AL-Mefty, who is definitely a master in skull-based surgery with a huge experience with petroclival meningioma, I have followed for many years his principles. He says that true petroclival are those originating from the upper or mid clivus, but most important, medial to 5. And they have a specific clinical and outcome because surgery is very challenging, which is not the case, for example, for some small anterior petrous apex meningioma. So this is my classification, I would say. I didn't make a classification of it, but this is what I consider as petroclival. For me, the epicenter must be in the petroclival junction. It can be more on the clivus, more on the tentorium, more on the petrous apex, depending. And depending of this little variation of the epicenter, it push most often 5 medially, but sometimes it push 5 inferiorly, more superiorly, and even in some cases, it can push 5 inferiorly and a little bit laterally. One of the characteristics for me is the invasion of the Meckel's cave, not infiltration, because it's usually a part of the tumor that is easily resected because there is still a layer of arachnoid, and sometimes it goes in the posterior cavernous sinus. Here is the Petroclival region. You can see that I think I have, yeah, I can use this, yeah. I am just trying to use a pointer, but I'm not sure it works. Yes, no. Hold on a second, give me 1 second. Okay. So this is a Petroclival region. It can arise here more on the clivus. It can really arise from the junction. It can also arise a little bit from the petrous apex, and also from the tentorium, anterior or posterior petroclinoidal ligaments, and below the tentorium. And you see that 5 that is really here, according to the epicenter, will be pushed in different directions. I like a lot this classification from Japanese colleagues because they add to their classification, to the epicenter, also the way, the direction of 5, of the displacement of 5, but also the feeders. And they describe 3 types. Tentorial type is pushing 5 downward. It's very logical because it's coming from up, down. So it's pushing 5 downward. You have this Petroclival type who is really pushing 5 laterally. And you have a more petrous apex type who is pushing 5 upward against the tentorium. This is quite dangerous in surgery because when you use a combined petrosal for those type of tumor, the anterior petrous type, sometimes the 5 is very thin between the tumor and the tentorium, and you may cut 5 when you cut the tentorium. And you see also that in this classification, the feeders are different. The feeders, for example, from the tentorial type are mainly coming from the Bernasconi artery. It's important in your surgical strategy because depending on the feeders, you may adjust your surgical strategy. This is another manuscript that was published in 2018. I advise you to read it because it's very interesting in terms of surgical strategy. They also focused on the feeders, and they say that depending on the feeders, they will adjust the surgical strategy. For example, if it's a tentorial type, you want to cut the tent early in order to devascularize the tumor. If it's a tumor with main feeders coming from the ascending pharyngeal, you know that it will bleed from the beginning to the end because coagulating the branches of the ascending pharyngeal artery are difficult. You don't have access to this part of the clivus easily. So in those cases, endovascular embolization before surgery can be very interesting. And I had a case where I had the surprise to see that the tumor after embolization was completely soft and suckable in less than 2 hours. Natural history of Petroclival is a very important topic because depending on natural history, you adjust your indication. This is almost the only manuscript really following patient for a long time that gave us some information about the natural history of those tumors. It's 21 patients, not so much, but they have been followed for a long time. 43% of patients were incidental finding. 76 of those patients had some growth. It's not surprising. A meningioma doesn't come from nowhere. If it's easier, most likely, if you follow it long enough, you will find some growth. 24% did not grow, which in my opinion is the most important information. So there is patient for which those tumors are not growing very, very much. And they also say that depending on the growth rate, you have a worsening or not of the symptoms. There is in the evolution of those tumors some change in growth pattern. It's not completely linear. And when you have a change in growth on serial MRI, you can predict that there will be a clinical deterioration on those tumors. So if you have a large meningioma that you are following for many years, but you see that in the last 6 months, the growth rate has changed. It has grown more than before. Then even if the patient doesn't have symptoms and if the patient is not old, it's maybe better to consider surgery before to see the deterioration of those patients. Small and medium-sized meningioma are difficult to make a decision on. It's a complex location. Most of us, when we see a 1 centimeter petroclival, we say, no, it's really not reasonable to do it. Surgery is not easy, and it doesn't grow so fast, so let it go, and we follow. This is acceptable, obviously, and this is what I do most often. But for example, in this publication from Ramina, they say that considering that surgery for large or giant meningioma is extremely challenging, it's a shock for the patient. Life after a combined petrosal for a giant petroclival meningioma will not be the same than before. We change the life of our patient, even if everything is doing well during our surgery. Considering this, maybe that it could be better in young patients, for example, finding a small meningioma that we have followed for 1 or 2 years. We know that it's taking 1 or 2 millimeters of diameter every year. It could be better, in fact, to treat the patient when it's easy to resect or to do radiosurgery, depending on the size, instead of waiting to have a big tumor. Sometimes we lost patient on follow-up also. And this is something we have to consider. The patient is leaving the city and is going to live somewhere else. And he forgot to do his MRI for 5 years. He goes back to a neurosurgery department because he starts to have symptoms. And now we have a big tumor that is much more complex to treat. And we may have difficulties to keep the functional status of this patient as it would have been easy to do with a very small tumor. So in this paper, Ramina is asking several questions in the discussion. Should petroclival meningioma be treated if asymptomatic? I would say the answer is no for upfront treatment. But if you follow the patient and if you figure out that it's growing significantly over the years, maybe it's a good idea to do it before it becomes difficult. Is weight and scan good for post-symptomatic or asymptomatic patient? Absolutely, this is what I do. Is a small petroclival meningioma enlarged? Should it be removed even if asymptomatic? Difficult question. Against, there is other factors to consider. In a young patient, it's not unreasonable to do surgery or radiosurgery in a small tumor that is asymptomatic but that is growing. With weight and scan, could operable small petroclival become inoperable? The answer is no. It doesn't become inoperable in 6 months, in 1 year. Most often they are growing very slowly, and if the follow-up is done properly, then you're safe. You cannot miss the good time for surgery. You have to know that calcification is associated with non-progression. If there is peritumoral edema, hyperflare T2 signal, it is more associated with progression. Tumor below 2 centimeters rarely become symptomatic within 5 years, even if it's growing after diagnosis. Is there other factors to consider, like sex? Is it worse in men than in women? Sex hormones? Yes, it's, in my opinion, very important. I am more worried with a petroclival meningioma in a man than in a woman. Why? This is a case of, it's not exactly petroclival, it's more petrosapex, but this is not the point. I saw this patient in office, a woman, she was around 40 years old, something like this. And this lady came to me with 2 MRIs, this one and this one, and there was about 1 year. So I saw this petroclival meningioma, and most of us would say it's really time to treat because this tumor is growing fast, and now it's starting to be symptomatic. She had some vertigo, and there is a significant compression of the brainstem. But this patient was taking cyproterone acetate, which is an anti-androgenic therapy. It's a progestative treatment. And just with stopping this drug, the tumor shrank completely. So definitely there is hormonal factors that we have to consider in order not to do surgery on tumors that would be controlled just with stopping those progestative treatments. What about stereotactic radiosurgery for small tumors? This is a big series, 254 patients. This is from Lunsford group. You can see that the volume of those tumors are mostly quite small. It's around between 1 and 2 centimeters of size. And you can see that the evolution is good for tumors below 8 cc's. Above 8, below 8 cc, sorry. Above 8 cc, you can see that you have more regrowths that are difficult to manage once it starts to regrow with surgery. So for radiosurgery, I think it's a very good treatment for small tumors, but for bigger tumors, we take the risk in young patients to deal with a difficult situation 5, 10, 15, 20 years after, because the tumor is growing again, and then surgery can be extremely difficult. It's much more difficult to do meningioma after radiosurgery than doing a schwannoma after radiosurgery, in my opinion. So let's focus now on large and giant tumors. This is an example of it. Typical petroclival, you see that the brainstem is pushed on the other side and posteriorly. The basilar artery is pushed on the other side. Significant compression of the brainstem. This is the clear definition of a large petroclival meningioma. This one, I consider it as a petroclival, even if it's extending quite far back on the petrous bone, but you see here that it's also going on the other side of the petroclival region. So this is petroclival, it's huge. This is a giant tumor. It's a big challenge. We did this case with combined petrosal, but with the drilling of the labyrinth because hearing was already decreased in this patient. So let's look at the literature. AL-Mefty is probably the most experienced surgeon with those tumors. He shows quite good result. I have to say, it's quite impressive. I don't know what's happening with my slide, but he's really in favor of a transpetrosal approach for those tumors. You can see that the results for the cranial nerve are very good. There is a significant amount of, you can see it here, of facial nerve palsy in his series that do not last. Most of them recovered. It's even better long-term follow-up than it was before surgery, but still this shows that transpetrosal approach have to deal more with the facial nerve, at least in the petrous bone. You can see here that 17% of the patient at follow-up have a worse Karnofsky index. So it's a significant surgery, and only 47% of patients at follow-up are improved in terms of Karnofsky index. This is his algorithm for petroclival, and you see that he doesn't leave much space to Retrosigmoid approach. What about Spetzler series? I think in BNI they have switched for the vast majority of cases from transpetrosal approach to more conservative approach such as Retrosig approach, at least behind the sinus. And I say, why not? I think most of those approaches are a question of experience. If you are experienced with a technique, if you have done 50 or 100 of petroclival meningioma significant size with Retrosig approach, well, you will definitely have better results than someone who is doing combined Petrosal but have limited experience. The only thing I would say about Spetzler series is that you can see in this series that the experience with combined Petrosal, he compared combined Petrosal with Retrosig, experience with combined is quite limited. Me personally, it took me a while before really understanding the principle, the concept behind the combined Petrosal. It needs a lot of work in the lab. It's definitely not like the Retrosig approach. It needs a lot of work before and a lot of experience to really get the benefit of combined Petrosal. Fukushima, another master in skull-based surgery, also in favor of combined Petrosal, but you see that he's using Retrosig approach more often than AL-Mefty. Excellent result also. Gross total resection, it's about the same for all the series. There is not much differences except for Ohata. I will talk in a minute. Ohata is also in favor of combined Petrosal. This was only a series of trans-Petrosal approach, 60 cases, impressive result in terms of extent of resection, impressive result also in terms of functional outcome. I like this diagram because it shows that even if there is a worsening of some cranial nerve in the postoperative period, most of those cranial nerve improve. And it's important in skull-based surgery, and especially for those complex cases, to tell the patient, you will have a bad time, most likely just after the surgery, but after a few months, you will get better. Here is the series from Seifert, Frankfurt. Huge experience also with Petroclival. This paper is interesting because he's giving more space to multidisciplinary treatment, multimodality treatment, surgery, radiosurgery, radiation therapy, combination of both if you leave a remnant of tumor. He is also using quite often trans-Petrosal approach, but he is also using most often Retrosig approach. About the cranial nerve deficit, functional outcome, it's similar to other series, the same for amount of resection. Hold on. Partager l'écran. I lost my. Yes. Sorry. You hear me still? Yes.
Yes.
Okay.
Yes.
Sorry. So in this table, you can see that he compared patient with gross total, subtotal resection with and without adjuvant therapy, and he looked at long-term control. So in case of gross total resection, the tumor recurrence is very, very low. It's 6%. In terms of subtotal or partial without adjuvant therapy, it's 26%. And if you do, if you do, I don't know how to go back. It was 12% if you do partial or subtotal resection. With postoperative radiation therapy, it was 12% of regrowth. Here in this table, he's looking at the morbidity. It's about the same. And here in this other table, sorry, I think I have a mixed with, hold on. No, this is this one, yes. So in this one, he looked only at a patient who had radiosurgery and radiation therapy alone, and 87% of those patients had a stable disease at follow-up. And of the 24 patients who only had observation, 54% of those had a stable disease. So I like this publication because it shows a different scenario that you can encounter with petroclival meningioma, and it's not dogmatic with surgery. Again, there is definitely a trend now towards functional outcome, and the combination for large and giant petroclival meningioma of surgery, decompression of the brainstem, decompression of the cranial nerve, and follow-up, and then radiation therapy is, I think, the most reasonable option. I will skip to go faster. So let's talk a little bit about our series. I will go fast on this. Large or giant petroclival, it's 50 patients in about 5 years. Some of the patients had hormonal therapy that was stopped, but didn't change really the growth rate. Some patients had a VP shunt before the surgery, and some patients were operated before. In terms of characteristics of the series, there is not much to say, except that a lot of patients were followed for a significant amount of time before surgery. Why? Because sometimes they were asymptomatic, sometimes they were not ready, because talking with those patients about the risk of the surgery, the patients were hesitating, and it's natural to hesitate when you don't feel any symptoms and you are exposed to such a risky surgery. So I am not pushing the patient to get to surgery. I'm not forcing the patient to go to surgery. I'm not frightening the patient. I think you need long conversation for large or giant petroclival with the patient. You need to see them again and again to really, for the patient as well as yourself, be ready for this surgical challenge. For the tumor characteristic, you can see that it was significant size tumor. The vast majority were large or giant tumors. There was brainstem edema in 38% of cases. This shows that it was mostly big tumors. We did preoperative embolization of most of the large and giant tumors, especially the giant ones. For the approach, I use anterior petrosectomy in 14 cases, combined petrosal in 24 cases, and adding a translabyrinthine approach in 5 cases. So I have to say that for large and giant true petroclival meningioma, I am mostly using the transpetrosal approach. 96% of the patient received an extent of resection above 80% of the initial tumor, which is in fact the objective of the surgery, in my opinion, which is brainstem decompression, the first goal of the surgery. For the cranial nerve deficit, I will not go in the details, but I'm not ashamed of my results. In terms of fascial nerve, we had a few, in fact, postoperatively, but most of them improved except one patient. And for the rest of it, it's quite similar to what is published in the literature. This is a permanent deficit, diplopia 4 cases, new deficit, hearing loss 3 cases, trigeminal hypoesthesia 8 cases. In my opinion, it's the most fragile nerve. You don't see it postoperatively because the patient is the same, but the patient feels it. And I think we underestimate the value, the importance of trigeminal nerve, because trigeminal anesthesia or dysesthesia, patient will have it for life. During the day, during the night, it will never leave him. If you have a fascial palsy, you can forget it. You can forget that you have this cosmetic issue on a daily life, but the 5, you cannot forget it because it's constantly present. Other complication shows that it's a significant surgery. It's a long surgery. You can have pulmonary embolysis because of the length of the surgery. You can have infection. You can have a lot of things. It's a major operation. Most of the patients had an improved Karnofsky index, and only 6% of the patients had a worsened Karnofsky index at the end of follow-up. I had one nightmare in my series that I will show you at the end of my presentation. So the treatment option for Petroclival, it's observation. As you understand it from the beginning of my presentation, I most often observe my patient before surgery. I think in only few cases, I would say 2 or 3 in my memory, I had to do surgery fast because of very severe symptom of brainstem decompression, and most often with swallowing issues. Swallowing issues, you cannot let it go for too long because first you can have pulmonary infection. I had a patient with bronchial dilatation, chronic bronchial dilatation because of long-standing swallowing issues. And if you let it go, it will make the postoperative period extremely difficult to manage. And most often you will not be able to avoid the tracheostomy post-op. So whenever there is swallowing issues, I go for surgery. I don't wait for swallowing issue to worsen. Again, when I do surgery, it's not to achieve a gross total resection. This depends not on me. It depends on the tumor. Sometimes you have very soft tumor. Sometimes you have tumors that are only going in Meckel's cave without anything in the cavernous sinus. If it's going in the cavernous sinus, I'm not going after it. If it's going in the Dorelos canal, I'm not going after it. If it's going in Meckel's cave, yes. So I don't remember exactly what are my gross resection rate, but I would say in 40% of cases, you can take it out, not because you're extremely good, but just because the tumor is good for it. It's soft and it's not extending in region where you cannot take it out without significant morbidity. Radiation therapy alone, yes, for small, as I said, mid-size Petroclival, I have definitely used it. It's a very good treatment. But for large tumor, I don't like it much, except if it's a palliative treatment. And I had a few patients, elderly patients, I have treated only with shunt. And just with a shunt treating hydrocephalus, I could keep this patient in a quite good condition for long, avoiding this major surgery. So here is a follow-up of those patients before operating in my series. So you understand that decision-making for those tumors depends on a lot of factors. You have patient factors, age, comorbidity. If the patient is fragile before the surgery, you have to be extremely careful. Patient wishes are extremely important. It's not like doing a small convexity meningioma that is growing or whatever. He risks his life. He risks his functional status. And again, most often he is not very symptomatic. So he has to be part of the decision. Brainstem edema, I don't like it. I definitely don't like it, but because it means for the minimum, it means infiltration of the pia. And for the maximum, it means that the tumor is fed by branches of the posterior circulation, most often basilar. And if you peel the tumor from the patient, from the brainstem, you can kill the patient. And he will definitely be in a terrible condition postoperatively. And leaving a carpet of tumor on the brainstem is not so easy because you never know exactly where to stop. And if you coagulate this carpet, you may also coagulate the perforators. So I don't like brainstem edema. Whenever I have it preoperatively, I am much more careful with what I am telling to the patient. I take much more time. Anatomical factors are important, and most important is your experience. Experience, you get it from clinical practice, but for transpetrosal approach, you get it from lab work. It's absolutely important. I don't think you can start doing anterior petrosal approach or posterior petrosal approach without having do it in the lab for at least few months. This is not what I did, and the research fellows that are coming in our lab, this is what they do. They understand the anatomy, they train, and when they will start with cases, they will be much, much more confident. So objective of the surgery, brainstem decompression is the first goal. Optic nerve chiasma when vision is impaired. On the cranial nerve 5 decompression when you have pain. Decompression of the oculomotor nerve, of the thesis nerve, no. Because if you try to decompress, most often you got a deficit. So this is really the goals of the surgery that we should have nowadays. What is the workup you need to do before the surgery? CT is extremely important, and CT most often give you the epicenter of the tumor because of the hyperostosis. And if you have the epicenter, you can classify. If you can classify, you can do a nice publication with homogeneous patient when you have significant experience. Pneumatization of the mastoid, extremely important. If you have a mastoid that is completely not pneumatized, and if you are starting with transpetrosal approach, it's not a good idea because it will be difficult to identify the semicircular canal, the fascial. In a well-pneumatized mastoid, it's easy to do. High jugular bulb, I don't like it because you lose the advantage of the infralabyrinthine approach to go to the mid-clivus jugular foramen. Temporal fossa floor, sometimes you have descents of the semicircular canal. And if you don't see it, you can lose hearing when you peel the dura. It's very rare, but more frequently, you may have a descent over the geniculate ganglion. When you peel the dura from the temporal fossa floor, you need to have a cranial nerve monitoring of the fascial, because if there is dehiscence and if you push too strongly on the geniculate, you will have an alarm for it. So here you have different type of pneumatization. It's a roadmap. Pneumatization is a roadmap for transpetrosal approach. I spend time to look at this pneumatization. If it is in my head, in my mind, then I just have to follow it. I know where are the difficult areas. I know, for example, here that I have 1 millimeter of cortical bone that will separate me from the lateral canal. So whenever I see this ivory cortical bone, I stop. So understanding the anatomy in the lab, understanding the anatomy on the CT scan is extremely important if you want to do transpetrosal approach. What about MRI? MRI, a lot of information, but more on the tumor. Looking at the signal on T2 is important because hyper T2 is usually a sign of softness. I am looking more and more at diffusion MRI. Diffusion can help you also with the consistency. You look at the extension, cavernous sinus, Meckel's cave, above the tentorium, and you look at the position of jugular bulb and the venous anatomy, which is extremely important for transpetrosal approach. Most of the cases have an angio. Again, we look at the feeders. The feeders influence the strategy. For example, if it's mostly coming from the ICA through the Bernasconi, cutting the tent is one of the primary goals of the final step of the approach, because once you have done that, your tumor is completely devascularized. If you have branches from the ascending pharyngeal, it's great with embolization. So here are the different type of feeders coming from the ICA through the meningoepophyseal trunk, coming from the ascending pharyngeal. This is drawing from one of my previous fellow, Kentaro Watanabe, who is back now in Tokyo. He was doing fantastic drawings like those. You have here the feeders on the tentorium. So this is the 3D angios images that you can get, and it really tells you where to put your bipolar on the dura to coagulate and control the feeders. So this is definitely important information. This is what I don't like to see, feeders and blush coming from the basilar artery, extremely dangerous. It's another level of surgery, in my opinion. So pre-op embolization, we did it quite often, 26 cases. And for the ICA, it can be challenging to get into the vessel for the endovascular guys. For the ascending pharyngeal, it can be risky, But I have to say that I have a very strong endovascular team, and I never saw a complication since I am in Lariboisière with the embolization of the ascending pharyngeal. Venous drainage issues are extremely important to consider, and you have to study this on the MRI as well as on the angio if you did an angio. This is a manuscript from AL-Mefty team about venous drainage. Very, very nice publication. The vein of Labbé, the drainage of the left temporal lobe must be understood before you do the approach. So the approach selection for me is based on the tumor type, on the extension. If it's going below the internal auditory canal, you will have difficulties to get it with a pure anterior petrosal approach. If it's going above the tent, it's going to be difficult to get it all from a posterior petrosal. Meckel's cave through retrosig or through posterior petrosal, I don't feel comfortable to dig in the Meckel's cave blindly. This is why I don't like this retrosig with the drilling of the bone above the internal auditory canal, because, okay, you can have access to it, but can you carefully remove without tracting the tumor into Meckel's cave? I don't think so. And if you tract, because the nerve here are very tiny before getting to the ganglion, I think you can avulse some of those fibers and have some injury of trigeminal. Depends also on vascularization, as I said, anatomical factors, patient condition, as usual. So for small and mid-sized tumor, I use a retrosig. It's a fantastic approach. It's an easy approach. There is absolutely no need for a posterior petrosal approach. Sometimes in bigger tumor, when it's really pushing the brainstem posteriorly, the anterior petrosal approach is nicer because your line of sight is more in the long axis of the tumor. This is typically a case for a retrosig. This is a case for a retrosig. It's not a Petroclival, it's a posterior petrous tumor, but you have a nice corridor here in front of the cerebellum and just above the cerebellum. For large and giant tumor, I use combined petrosal or anterior petrosectomy purely. Anterior petrosal is a well-known approach. I think it's a neurosurgical approach. You come from the temporal side, you drill the petrous apex, and you get into the posterior fossa. This is a view of cadaveric dissection on the right side. You can see here the third nerve. I just take again the, yeah. You can see here not the third, the V3 here, posterior fossa dura, temporal dura, and here the superior semicircular canal. This is KAWASE Triangle, which define the area where you can drill to get access to the posterior fossa. What you drill is the petrous apex here, the bone above the internal auditory canal, and sometimes the bone between the internal auditory canal and the superior semicircular canal. It depends on what you need. What is the advantage? You are not crossing the nerve, you have a more anterior line of sight, and you devascularize the tumor first. This is one of the big advantages of anterior petrosal for those upper located Petroclival, compared to retrosig, for example. It's quite easy to devascularize just by coagulating the dura. And then you may have a tumor that is very soft. You have a nice access to Meckel's cave. You have access also contralaterally if the tumor is really covering completely the brainstem. I will go fast on this, just to show you in this case that, for example, it's completely pneumatized, so the anterior petrosal approach is already done. You just have to open the cortical bone of the superior surface of the petrous apex. You get into the cavity, you take the wall out, just like being in a sphenoid sinus, and then you get to the cortical bone here, posterior surface of the petrous apex, anterior aspect of the internal auditory canal. And here, posteriorly, you don't need to drill. Or if you drill, you know that you have 4 or 5 millimeters before you get the cochlea. So pneumatization is your roadmap. Here, there is non-pneumatization, but you have cancellous bone, which is very soft. So you remove the cancellous bone, and at the end, you have a thin layer of cortical bone that you have to drill with a diamond, and that's it. Height of the cochlea is important. If the cochlea is deep, there is no worries. If the cochlea is really close to the surface, which doesn't happen very often, then you have to be careful with the cochlea in between labyrinthine portion of 7 and GSPN. Positioning, I use a supine position for anterior petrosal, question mark incision, monitoring. Position is important, rotation of the head, it depends on your target. If you position 90 degrees in this case, you will go naturally towards the petroclival junction, but not towards the base of the tumor. So rotation, there is no rule. It depends on the position of the tumor. Neuronavigation can help you to find the good rotation of the table to have the best ergonomy to work. Soft tissue dissection, interfacial. I don't remove the zygoma, and I do a retrograde dissection of the temporalis muscle. Then you peel the dura from back to front gently, because you can strip GSPN from the geniculate if you're too strong, but you have the support of stimulation. And then you find your landmark, subarcuate eminence, middle meningeal artery on the foramen ovale, GSPN. And then you have your KAWASE triangle. Coagulation of the middle meningeal, you leave a few millimeters of middle meningeal. You don't want to have the middle meningeal bleeding into the foramen. Then you identify GSPN. To identify GSPN, having a stimulator is very important. This is a dissection. Where is GSPN here? Is it here? Is it here? Is it here? Here? It's tough to say if you don't have a stimulator, because you have fibrous tissue here, remnant of periostal dura on the floor that you can misconsider as GSPN. So the stimulator will tell you that GSPN is here. I don't unroof foramen ovale in most of the cases, and then you peel the dura from the nerve. Peeling of the dura from the nerve, the principle is to elevate the dura, to cut the periostal layer, and then to peel the dura propria, like you can see it here. And then you expose V3, sometimes V2, to have more laxity of your dura to be able to expose the petrous apex. This is the view of KAWASE triangle with the post-meatal area, the suprameatal area, and the premeatal area, which is most often what we drill during anterior petrosal, but sometimes you have to drill above here and you have to drill behind if the base of the tumor is going quite far posteriorly. This is how I drill. Start here, then medially, because here it's safe, then you go to the carotid, then you go back to the cortical bone, then you follow internal auditory canal, and then you go to the cochlea, the most risky area. And if you need it, you go to postmeatal. And don't forget to drill also below Gasserian ganglion Meckel's cave, because this is also where is the tumor base of the tumor. So if you want to devascularize, this is below Meckel's cave that you will have to coagulate, being careful with Dorello's canal. Okay. So once you have done the approach with the anterior petrosal, you have to section the tent. And on section the tent, you just have to be careful with the trochlear nerve that enters the tent here. If you go too anteriorly with the incision of the tent, you may cut trochlear nerve. And this is the final view. You see that if you have a petroclival meningioma in this area, it's very nice because you've got the base and then you just have to tract it out from the nerve. You don't cross the nerve, which is something that you have to do with the retrosig. If the tumor is going down, you can still put an endoscope to look down and to take the lower aspect of the tumor. But if it's going down and posteriorly towards the facial nerve, then it's dangerous. And then I prefer to use retrosig or posterior petrosal. because controlling the fascial nerve, the cochlear nerve through an anterior petrosectomy is not very easy. I will skip this case and I will go directly to the combined petrosal. So combine is the approach that you use for the big tumors, the tumors that are going below the internal auditory canal, that are going above the tent also. I mean, those tumors extending from quite far down to quite far up. You don't do this for a 3 centimeter Petroclival, for example. You do it for a 4 centimeter, 5 centimeter. What is the advantage of combine? It gives you multiple directions to look at the tumor. And this is what I love with this approach. And you have a direction, optimal direction of looking at the tumor for each cranial nerve. For each difficulty, you can adjust the way you will look at this difficulty to make this difficulty more simple. So in order for you to really understand the concept of the combined petrosal, I think it's nice to compare it with the FTOZ approach. If you understand this concept, it will be, I think, much easier, and it will demystify this approach that maybe most of the young neurosurgeons think it's extremely difficult. No, you need to understand the concept behind it, and you need to work in the lab. And once you have done those two things, you can start to practice it, to do it in surgery. This is an FTOZ. You can see temporal dura here, frontal dura, and the orbit. This is the view of a combined petrosal. You can see here temporal dura, posterior fossa and cerebellum with the sigmoid sinus, and here you have the petrous bone. So orbit, petrous bone, vestibular system, hearing system, and you have here the sphenoid pyramid, and here you have the petrous pyramid. So if you look at those two views, it's the same. But for the FTOZ, you are working between temporal lobe and frontal lobe. You have to do the same for the combined petrosal. Here, if you don't open this space between temporal lobe and frontal lobe, you understand that you have to work only through the sphenoid pyramid, and it's very small. It's exactly the same here. If you work only through the volume given by the drilling of the petrous bone, it's very small. It's useless. It's not an approach. It's an ENT approach to get to petrous bone lesion, but it's not a neurosurgical approach to get to central skull-based lesion. For this, you have to open this sulcus between temporal lobe and the sigmoid and transverse sinus. So the combined petrosal, I think, is a misnaming of what we should call, in fact, the mobilization of the sigmoid and transverse sinus. Fronto-temporal approach, you do fronto-temporal craniotomy. Combine, you do temporo-occipital. Fronto-temporal, OZ, you work between frontal temporal lobe, combined petrosal between temporal lobe and cerebellum. Here you drill the sphenoid ridge, here you drill the petrous ridge. Here you work along the orbit, and you don't call an ophthalmologist to help you for that. Here you work along the labyrinth. You don't get into it, but you drill just the petrous ridge. You don't necessarily need to work with an ENT for that if you know why you are doing it. Whenever I do translab, I have a tendency to call my ENT colleague, because drilling the labyrinth, drilling the vestibule, drilling the middle ear segment of the facial nerve, I don't feel comfortable with this because I don't do it often enough. Drilling the anterior clinoid process, this is what you do sometimes at the end of the FTOZ or frontotemporal approach. Here, you drill the petrous apex, except that for the petrous apex, you switch a little bit below the temporal lobe to drill it, just like you would do it with the frontotemporal approach. You will move a little bit below the frontal lobe to drill the anterior clinoid process. So initial steps is a C-shaped incision, like this. I used to do question mark with a counter incision behind the ear, but then I follow Fukushima technique, C-shape, Ohata. I think AL-Mefty is doing the same. It's much easier. Then you do an interfacial dissection. Why? Because with the C-shape, if you want to retract the skin flap enough anteriorly, you need to separate skin flap and muscle. And if you do that, you want to avoid injury to the frontal branch. You need to expose the zygomatic arch. And this is here the soft tissue dissection. So here is a retrograde dissection. You want to keep this layer of periosteum below the temporalis muscle intact because you have vessel and nerve for the muscle. If you keep those intact, you will not have atrophy of the muscle. Here I elevate the nuchal muscle from the occipital bone and then start the bone flap. What about the bone flap? There is two techniques, two schools. One school is drilling the mastoid first, isolating the sinus, and then you do the bone flap. This is what I was doing at the beginning, and I think it's good to do that at the beginning because the sinus is the most difficult structure in combined petrosal. If you enter the sinus on the left side, surgery is over. So you have to put everything to keep the sinus intact. If it means that you prefer to drill with a diamond over the sinus before doing this bone flap around the sinus and not being very comfortable with it, why not? Now I have changed. I have to say I do the bone flap first because I want to keep the cortical bone of the mastoid intact to use it for reconstruction. So I do a bone flap, L bone flap like this, temporal, suboccipital, in one piece, two piece, three piece, whatever you want. It doesn't matter. We have plates to reconstruct. The only thing you need to keep in mind is saving the transverse sinus. Once you have this, I do the mastoidectomy, but I start with a chisel to really elevate the lateral cortical bone of the mastoid, being careful with the angle between sigmoid and transverse sinus. Sometimes it's not very deep, so you have to be careful with the seizure. And I keep it for the end of the surgery to reconstruct because like this, the patient do not have a hole behind the ear, and sometimes it can change also the ear itself. So then you go to the mastoidectomy. Mastoidectomy is a simple step. An ENT resident, after 1 or 2 years, is able to do a mastoidectomy. It's one of the first surgeries they are doing in otology. So it's definitely accessible to a neurosurgeon. But again, they have a drilling course. Neurosurgeon should have drilling course in the lab for the petrous bone. I start with a 5 mm cutting, identify the structure, sinus, identify the temporal dura, identify the external auditory canal. A common mistake is to go too deep, too fast, before identifying the structure on the surface. For the sinus, I use 5 mm diamond with a lot of irrigation. There is almost zero risk of getting into the sinus if you use it like a pen, smoothly. Then you get into the antrum. Once you are into the antrum, you push the drilling of the middle ear a little bit forward, and you will start to see this structure that is mobile. This is the incus. If you look in the direction of the short arm of the incus, it's like an arrow that gives you the direction of the facial nerve. It will be here. Just above it here, you start to see ivory bone. This is the lateral canal. And then you don't have to go back in the middle ear again. The more you open the middle ear, the more it will be difficult to close at the end. And you have to close the middle ear at the end because this is through the middle ear that you get CSF leak. But if you have done a large opening of the middle ear to close it, you will disturb the ossicles and you will lose hearing because of otitis media. So then you identify the labyrinth, the structure you want to keep intact. You work on the sinodural angle, you find the endolymphatic sac, and you go infralab, following the sinus down, getting to the gulf. And this is done for the posterior petrosal approach. Here, if you want to work in the infralabyrinthine corridor, because the tumor is going quite far down, you may need to identify the facial nerve. Facial nerve is here. You move progressively forward with a 3 mm diamond, pure diamond, with a lot of irrigation and with the stimulator. And progressively, once you start to see the fascia, you don't need to uncover it. You just need to know where it is. Once you know where it is, you can stop. There is no need to complete. Then, I'm sorry, I don't know. Oh no, I can go back here. Then you have to move subtemporal, once you have done that, to do the anterior petrosal approach that we have looked at before. You drill KAWASE triangle, you drill above the internal auditory canal, you drill the postmeatal triangle, which is much more easier to drill because you know where is the superior canal, you have unroofed the labyrinth. This is also pictures from Kentaro, absolutely beautiful. This is art, in my opinion. So you have to understand that this combined transpetrosal is not a retrolabyrinthine approach. Posterior petrosal is not retrolabyrinthine approach. This is retrolabyrinthine. This is done for ENT pathology. But this here, this little tiny space here, doesn't give you what you need to have access to a big petroclival. This is too narrow. So what you need, the space through which you will work, is the space here that you create with the opening of this sulcus, of this fissure between temporal lobe and between cerebellum, pushing, mobilizing here this sinus. This is what we would do in an FTOZ, but we cannot do that here because we cannot cut the sinus. So we have to find another way to unlock this sigmoid sinus. We do an incision here that has to go quite far back above transverse sinus. We do an incision here in the posterior fossa. We cut the superior petrosal sinus. We cut the tentorium, and then we can mobilize it posteriorly and look at this fantastic direction that you have from down up, posteriorly, anteriorly, and laterally, medially. And you understand here that it's a fantastic access to the central cistern behind the infundibulum. This is why AL-Mefty is using it for big retroinfundibular craniopharyngioma that are going high, because you can look at almost at the third ventricle from below. And I used it several times for craniopharyngioma, and I was happy with it. Okay, I go fast. I'm close to the end. I'm talking definitely too much. So as we said before, approach are adjusted to the feeders. With the tentorial resection described by Fukushima, you devascularize the tumors. When you have done the exposure, you have cut the tentorium posteriorly, you need to do an additional anterior cut. Why? Because first, with this anterior cut, you will devascularize, anterior cut here. And secondly, this is a window towards the tumor. The tentorium is hiding you the tumor. Once you resect it, it's like opening a window on the tumor. Look at this manuscript from AL-Mefty, from Fukushima, sorry, 2012, with this tentorial detachment. It's a brilliant, brilliant technique. Then if you have feeders coming from the ICA and clival artery, anterior petrosal is perfect. You devascularize the tumor just by coagulating the dura. If you have branches coming directly from the ICA, you may be able to embolize it, but it's more technically challenging for direct carotid branches for the endovascular. When it's coming from the ascending pharyngeal, then it's perfect for endovascular treatment. And this is what I do most often. Sometimes feeders come only from the ascending pharyngeal. Remember that if there is hearing loss, no need to work around the labyrinth. You can drill it. And for this, asking an ENT to help you, I think, is definitely a good idea. Closure, most important is to close the middle ear. thin layer of bone wax, layer of pericranium over it, fibrin glue. I close the middle ear under the microscope. I cross finger. Until now, I don't remember of any CSF leak. I had meningocele, but not CSF leak. And I use fat. Fat is a fantastic sealant for skull-based surgery. Big piece of fat, snowman, and it works perfectly. It's a challenging approach with a lot of risk if you are not trained in the lab with it, and if you don't spend the time needed to anticipate those complications. Most of the complications we encounter in surgical approach, we can anticipate it, we can avoid it, and we can find the solution looking at the preoperative workup, CT scan, MRI, Angio. I show you a video of combined Petrosal. So this was a significant case, C-shape incision. This is a bony landmark. This is the bone flap drawing. We did one piece here because it was a young patient and the dura was not adherent. Otherwise, we do 2 or 3 pieces. You saw the cosmetic mastoidectomy. Here is the drilling of the mastoid. Getting here to the antrum. Short arm of the incus gives me the direction of fascial, and then I find lateral canal, posterior canal, superior canal. And then you follow the dura. I just want to identify the fascial nerve to have the most anterior extent possible in my infralabyrinthine corridor. I drill here behind the posterior canal. I'm happy with my approach, posterior petrosal, and now I move anterior petrosal. Coagulation here of the middle meningeal, peeling the dura from V3. All this is done under the microscope. Not too much traction, not only blunt dissection, sharp also to avoid traction on V3. And progressively, you expose KAWASE triangle. I was using before retractors to expose the petrous apex for anterior petrosal or combine. I'm not using retractor anymore. Just with the suction, dynamic retraction, vertical view with your microscope. For the young neurosurgeon, remember that skull-based surgery, most important concept is that you create space through bone. If you are not using after, just because your microscope is not vertical enough, then you did this drilling for nothing. Here is the resection of the tent. This is the anterior detachment. And you will see how this resection of the tent completely exposes the tumor. Fourth nerve is difficult to keep in those big tumors. I think that a lot of patients have already compensated their force, which means that even if you lose force, sometimes they don't complain much. They may complain of diplopia when reading. 6 is definitely the most difficult nerve to identify. And in all the series, it's a nerve that is lost most often. Look at this, it looks like a convexity meningioma. And then you use pincette, 2 pincette technique to dissect the nerve, to dissect the arachnoid, to peel the arachnoid from the surrounding, from the meningioma. You keep the arachnoidal plane by peeling the arachnoid from the tumor. Not working in the cistern. If you work in the cistern, you're not in the good plane. You are in the good plane if you peel the arachnoid from the meningioma. This was 6. You see the basilar anteriorly, and this is the final resection of the tumor. You can see 6 here going into Dorellos. And look at small multiple angle of view that you have. I can look at the different limits of the tumor from different directions. And this is very nice. For each cranial nerve, I have the optimum line of sight. Closure, fat, glue, on the bone. Okay, this was another one I'm going to go fast on this. You saw one, it's already fine. I think at the end of this video, one thing that is very nice is how you can change the angle of view. It was quite a complex one with multiple balls. And this is the final view. This is third, contralateral third. This is 6. This is basilar bifurcation with contralateral third. This is PCOM, this tiny vessel. There was a perforator inside the tumor, so I left a little piece of tumor. But what is nice with this approach, as you can see it here, is that you can see the tumor bed from multiple directions. And this is a very important comfort to take those tumors out, giving the maximum chance of preserving the cranial nerve. You see all those directions, looking down, looking up, looking below trigeminal nerve, multiple directions here. This is the basilar clivus. This is the third contralateral, PCOM homolateral, probably third in the depth, homolateral. You can really browse completely the skull base. You can do it at the end, but you can do it during the surgery. And this is the advantage. If you do a retrosig for a wide, large tumor, you have only one entry point. Okay, I believe, so brainstem edema, I finish with a complication. It's always good to finish with complication. I think, yes, I think it's mixed here. This was the tumor preoperatively with the edema. It was a patient that was 55 years old, growing tumor. I waited quite a long time. I was pushed to do surgery, but I waited because I was not feeling secure with this edema. Finally, I decided to do it. He was not so bad, but he started to have some swallowing issue, but he was having a normal life. During the surgery, I had 1 second of inattention and I cut PCOM. On cutting PCOM, I cut perforators. I controlled the bleeding. It was easy. Patient wake up. Huge brainstem infarct. And this patient was tetraplegic initially. He recovered one side. He's hemiplegic. He has a track. He has a tube. So devastating complication. This shows you that it's a major surgery, major risk. So you need to be prepared. You need to be trained. You need to be prepared. If you are trained and prepared, you can have quite good results for those challenging tumors. But most of the work should be done now during your training, working in the lab, if you want to be able to do it, those type of surgery one day. Combine is dedicated, in my opinion, to cranial nerve preservation, but it works only if you know what you are doing and if you understand the concept. Thank you very much for your attention. I'm sorry for being too long, but I like this subject so much. I cannot stop talking. Thank you.